Hello. Thanks for letting me join and talk about some really exciting things that are happening at Cascade Medical Advantage. My name's Katie Waller. I am a nurse practitioner that works at CMA. And for those who aren't familiar, CMA is a not-for-profit private substance use disorder clinic that is located at the Chestnut Professional Building off Chestnut near downtown. I'm going to jump right in. So just to make sure everyone's on the same page as to what we're talking about, I want to start with buprenorphine. So buprenorphine is one of the 3 FDA-approved medications for opioid use disorder. We call these MOUD. And I've heard buprenorphine aptly described as a slight tickle and a tight hug. I'm going to go over that a little bit more in depth with my next slide. But importantly, buprenorphine is considered one of the gold standard treatments for opioid use disorder because of its impressive over 50% reduction in mortality for folks when maintained in treatment. This is especially true if they're maintained for at least 6 months, even more so if they're maintained for a year or more. And it is vitally important for folks who have experienced a non-fatal overdose and is a really important intervention to offer at that time. I just really cannot emphasize enough how significant a 50% reduction in death is when it comes to a medical intervention. There are very few, if any, medications that offer such significant improvement in outcomes that actually matter to people. Like, people do want to be alive in general. But there are some challenges. So because of access issues, various barriers that are in place, and importantly, stigma, only about 1 in 5 people who would benefit from MOUD actually receive it. MOUD, specifically buprenorphine, has been around for decades in a sublingual form of tablets or films. And while that's a crucial medication, there are various pros and cons to that. And the LAIB fills in important gaps that exist within that treatment type. And again, just offers choice for folks. There's also been challenges in the era of fentanyl with getting people on treatment. So even though it's already an access issue with 1 in 5 folks actually getting on the medication, of those folks who attempt to, we see that only about 1 in 3 are successful in getting on the medication. And again, 1 in 5 retaining on treatment. And again, that's of the already low amount that get opportunity for that. And this is even worse for folks who face homelessness and other structural and systemic barriers. Really quickly, these are the 3 medications. I'm going to specifically talk about buprenorphine just for the purpose of this talk, but when I said that slight tickle and tight hug, what I mean is buprenorphine is a partial opioid agonist. So it sits in the receptor, but not perfectly like a full opioid would. Full opioids meaning methadone, fentanyl, oxycodone, just kind of the usual opioids we think of. So it sits in there, but it doesn't activate it in the same way. So whereas full opioids can cause euphoria and at higher doses cause respiratory depression, which can lead to overdose and death, buprenorphine doesn't have that risk. So it's a slight tickle rather than a big slug. And the tight hug refers to the fact that buprenorphine has the highest affinity for the opioid receptor, meaning that when it is there in the opioid receptor, it's going to stick in there like a magnet. It's not going anywhere until the half-life runs out. Maybe someone stops taking it, but it is blocking any other opioids that would try to come and sit in those receptors. So that helps protect from overdose. And that also does cause the risk of precipitated withdrawal, which is what people are really scared about with buprenorphine. And I'll talk about why LAIB is a good option for that as well shortly. So LAIB is this long-acting injectable formulation. It's been around, Sublocade was the first. It's a monthly shot that's been around since 2017. And Brixadi comes in weekly and monthly formulations, has been around since 2023. In a survey of SUD treatment programs and clinics a few years ago, it was found that about 30% of those places offer LAIB. At Cascade Medical Advantage, we've been offering this choice for years. And really cool is that a grant through the Washington State Healthcare Authority this year allowed us to further increase access and timeliness of treatment for this medication. So the 2 points here is that 1, the timeliness of treatment. So previously, if a patient's interested in LAIB, we'd talk with them, make sure that they were a good candidate, eligible, that sort of thing, and we'd have to order it through a specialty pharmacy. That ordering caused a delay. Sometimes it would take a few days, a week, sometimes more, depending on insurance issues. And then that also offered an opportunity for patients to get what we call lost to follow-up, or they may not come back for that shot, even though they were very interested and wanted to start, just a few days earlier. And oftentimes that's not because they don't want to, but it's because of, all the various challenges that they are facing that precludes them from coming back. So now we have this medication in stock, on demand. We can start people the same day that they're interested. And the increased access comes from the fact that the first round of this grant allowed us to provide this medication to uninsured, underinsured, and Medicaid recipients without any cost burden to the patient. The second round of the grant will be for uninsured and Medicaid, but we are very committed at CMA to providing this choice of LAIB regardless of someone's ability to pay. Along with the timing of this grant, in the past few months and few years, there's been novel approaches to starting LAIB across the country. These are called direct to inject, rapid start, or cold start, but they all essentially are starting folks on LAIB without them having to previously have a sublingual dose as a test dose or be stable on sublingual formulations before getting the shot. So again, organizations all over the country, Alaska, California, New York, and other places in between, have been investigating this option to overcome access challenges, treatment timeliness, and those challenges with getting on buprenorphine in the fentanyl era, where we saw those really low success rates and retention rates. I've got examples with some slides at the end that I'll have available for folks if you're interested, but in the sake of time, I'm going to not go through each and every one. But ultimately, what they found is that there has been a really low risk of precipitated withdrawal. And again, that is what people are scared of. This is real. It feels awful. People don't want to experience that. And so that is a barrier for people to start this medication. But because of the unique way that the long-acting injectable gets slowly introduced, the precipitated withdrawal risk is lessened. They've also seen high engagement from folks, higher retention in treatment rates, and people report decreased cravings, decreased use, and there has been no overdose or death in the folks that have been studied. So while this has been happening all over the country, our neighbors to the south in Seattle have also been working on this at the Downtown Emergency Service Center. They've created a 3-day protocol, and this is meant to provide overlapping doses that mimic what's called microdosing. So microdosing in the traditional sense is taking very, very small doses of buprenorphine and slowly, subsequently increasing those doses over the next few days. This usually takes anywhere from 3 to 10 days with the goal of minimizing that precipitated withdrawal. However, this comes with a lot of challenge for folks trying to manage this protocol when it's being done the traditional way. So I want you to imagine if you're prescribed an antibiotic and you have to take that antibiotic 3 or 4 times a day, how challenging is that for you to remember? And it's the same case for these folks. And imagine this in the context of someone who is unhoused, doesn't know when their next meal is afraid that their medications might be stolen, might not have a great way to cut the film or the tablet, and just how difficult that is in general. So the way that the shot 3-day protocol works is that patients aren't having to manage it. The shots are doing that management themselves. So we've learned through DESC, through webinars, we've had direct conversations and communication with them. They've shared their resources, and they've also had a recent publication in JAMA Network Open on August 15th, which describes their experience and reports on the 95 people, or the first 95 people that they've engaged with this protocol. Of those, almost 80% were unhoused or in permanent supportive housing. And they found that 75% of those patients completed the first 3 days of the protocol, and 64% received a second dose 1 month later. And if you think back to the beginning of these slides, where I said that about 33% get on the medication and 21% receive a second dose, you can see the benefit that comes from this protocol, especially in a population that they're particularly trying to meet. So at CMA, we have adopted algorithms for both 1-day starts, which has been what's largely been studied across the country and is referred to in the slides at the end of this deck, and then also the 3-day approach from DESC. What is really, really cool and the opportunity that we have at CMA is because of this HCA grant, we have these doses in stock and again, available to start folks on the same day that they're interested. This has been one of the biggest logistical barriers that has been reported by all of these entities across the country, including DESC, is that they're still having to deal with that ordering through insurance and that subsequent delay. So we get to circumvent that And it's very cool because we can get folks the treatment that they are interested in, that they need, and that is going to help save and change their life. Again, we're committed to providing access to this medication regardless of ability to pay. We're tracking our outcomes, and what we ask of you all as our community partners is to just have awareness, engagement, and collaboration with us. So one, share widely with your folks, with the people who need to know this, people who are at the front lines working with patients, and people who have opioid use disorder. Reach out to us if you have questions, if you want to learn more, if you want to know how exactly logistically that would work. If you want to come see the clinic, we are here and we want to collaborate with you all. And just to that end, let's work together. We all have our own special positions in this work. We all shouldn't and cannot be doing it all, but the better that we work together, I think the better we can see outcomes improve. This is just an example of a patient decision aid that I've created to help folks decide what is the best option for starting buprenorphine, whether it is the shot, which option, or just the traditional sublingual buprenorphine. And then finally, I want to share a case study. So at the time of this recording, we have had one patient who has tried this protocol. This was a male who was unhoused, and at the time of our first meeting was actively using fentanyl and methamphetamine. He'd previously attempted the low-dose traditional microdose start, which took him over 7 days, and he was ultimately not successful because it was so difficult for him to manage that on his own. He was brought in by an outreach worker, so shout out to Kilmeny, and he ended up choosing the 3-day option, and he successfully completed all 3 of those days. He came back a week later just for a check-in, see how he was doing, and we decided it would be best for him to get a booster dose. And then he came back and he received his monthly dose, the second monthly dose. So he is already beating the odds. He's reporting that he felt the buprenorphine, but no precipitated withdrawal. And he was ultimately really grateful that he didn't have to do that management that was so difficult for him before, that the shots were just doing that for him. I want to give him credit because he attended at least half of his visits on his own. There was a lot of communication and collaboration with Kilmeny because this gentleman does not have a cell phone. But that tells me that of his commitment, and that this was working well enough for him that he felt it was important enough for him to get to the clinic on his own to continue. He's seen a significant decrease in his fentanyl use, and this is helping to facilitate him to get into a tiny house, and he plans to continue follow-up for subsequent doses. I've got references available for those who are interested, and as mentioned, there's slides discussing experiences across the country with this to give credence and credibility to what's going on. But I just want to thank everyone for your time and attention. My colleague and medical director, Dr. Adam Cartman, is available for questions if anyone has that, but please reach out, engage with us. Let's work together on helping folks who really need this medication and access and helping support them in the recovery that is best for them. Thanks all.